My name is Akshara Menon, and I am a Senior Legal Analyst and ORICE Fellow at the Public Health Law Program at the Centers for Disease Control and Prevention. And it's my pleasure today to be your moderator for our webinar on electronic health information, assessing the impact of law. This webinar series, as mentioned, is co-sponsored by the CDC's Public Health Law Program and the American Bar Association Health Law Section.
Thank
okay,
you,
great. So I'll jump right into my slides here. I'm Jonathan Carmel. I am an attorney who works for the New York State Department of Health. And in the most general sense, I'm talking about the government accessing electronic health information. So just to introduce that topic, one way the government could access health information is as a healthcare provider. The government often operates hospitals, nursing homes, or other types of facilities that provide healthcare. The government could access information as a health plan. Of course, most, New York State has a Medicaid program, for example. That's a health plan. Those are two ways the government could access information. But the focus of this talk is disclosure of electronic health information to a public health authority for public health activities authorized by law. And I'm using those terms because HIPAA uses those terms, and that's an example of a disclosure that HIPAA allows without any authorization from the patient. So moving on to the next slide, different healthcare providers disclose information to public health agencies for a variety of purposes. In New York State, there's where I work, the New York State Department of Health, and also New York City has a degree of autonomy, and the New York City Department of Health and Mental Hygiene also has a lot of information reported to it. So on the next slide, I'm representing here the traditional siloed approach where information comes into many different programs for specific purposes. So there's traditional public health uses like communicable disease reporting, STD reporting, other types of disease reporting. For a long time in New York State, we've had something called Sparks, where all of the hospitals provide us with information that's very similar to the claims data that's submitted if you're making a claim to Medicare. And there's other public health reporting that's required to public health agencies. So on the next slide, there's also authorized reporting to a public health authority. So in some cases, we're doing public health research, and we have authority to do that, and healthcare providers may give us information to do that, but it's not a mandated reporting requirement. Even though it's not required by law, it's still authorized by law. So again, HIPAA would allow that type of disclosure without authorization from the patient. So then on the next slide, I'm talking about a slightly different category, at least under HIPAA, which is required reporting to a health oversight agency. So probably like a lot of state health departments, in addition to doing public health work, we also oversee healthcare facilities that we license and regulate. So as the licensor and regulator of hospitals and nursing homes and other types of healthcare facilities, they're required to report certain information to us, and that information may be used by us to take enforcement action against the facility. So that's not the focus of what I'm talking about today, but that's another way that the government collects electronic health information. Okay, so on the next slide, there's also required reporting for law enforcement purposes. Sometimes this type of reporting is made to the police authorities, such as in New York State, certain gun and knife wounds in hospitals have to be reported to the police. There's child abuse reporting. those things are not reported to my agency. They're reported to other governmental agencies. Within the New York State Department of Health, we do have the third silo here, which is the iStop program, which is certain reporting to our Bureau of Narcotics Enforcement, which is within the New York State Department of Health. And again, that's really for a law enforcement purpose because we're trying to prevent drug abuse and other controlled substances offenses. Okay, so the next slide with the map of New York State. And now I'm going to try to put all of this in context. So what I've been talking about so far has for many years been electronic health information. It's not been for many years a case of all of these reporters mailing paper records to us. That's not how it's done. So the initial electronic way of doing it in New York State, we have something called the health commerce system. So that type of system would be a system where somebody has a user rights and they log into the system and they can upload information and it can be transmitted to us. So that's one way that things have been done for many years. We have more recently moved to an automated system which we call the Universal Public Health Node, UPHN. That's similar to the first thing I said, except it happens automatically. So if there's mandated reporting, nobody has to log in and upload the information. It's just funneled to us automatically. And all of that is electronic. But the big new thing that is what we're, I think, really talking about today is new systems that are going to create interoperable electronic health information systems so that anybody with an internet connection has the technical capability to access information through a internet-based portal. So as a lot of you, I'm sure, know, under the HITECH Act, there's certified electronic health record technology, and the purpose of that is to allow interoperability of electronic medical records. So that's really what we're talking about today. And the system that's being set up in New York State already has a bunch of regional health information organizations. They're also called health information exchange organizations, but in New York we call them RIOs. And so they exist throughout the state, and within those regions, healthcare providers are participants in the RIO, and it allows the RIO participants to exchange patient records with each other for the purpose of treating patients. That's, of course, the first and most important use case, is to allow healthcare providers to access a patient's medical history in order to provide treatment to their own patients. And that's the initial thing that's being set up. Okay, so then on the next slide, we're moving on to, sort of the next stage of this, which would be to allow us in the government to also access information using this same system for public health activities that are authorized by law. So in this slide, there's a picture which shows lots of different types of healthcare providers, and they each have different laws that are applicable to them. And information is made available by one of these health information organizations, and the New York State Department of Health and the New York City Department of Health and Mental Hygiene already have some access to this information, but in the future we will have more and more access to information in a system that will eventually not be a totally siloed system, but it'll be a totally integrated system where the information can be used more efficiently when you just have individual providers sending information to individual siloed programs. So then on the next slide, I'm going to talk about some of the issues. So like I said, when you have these health information organizations, they enter into participation agreements with the participants. And most of the participants are healthcare providers, hospitals, physician groups, other types of healthcare providers that are putting information into the system and accessing information from the system for the purpose of treating patients. And so that's under contractual participation agreements. If the government is going to access information from a health information organization or health information exchange organization, as they're called in some places, question number one is, well, does the government need to enter into some type of participation agreement? Preferably from the perspective of the government, we would not want to have to do that because we think, oh, well, we just have authority to access this information. Why do we have to enter into a contract essentially with the people that we're regulating? But as a practical matter, there needs to be some type of arrangement that says who exactly in the government is going to be a user and why are they accessing the information, what's their legal authority to do it, you know, and there has to be some kind of audit trail that's created of who's accessing the information and why. So if there is already a participation agreement that's been created, it's possible that that participation agreement was just created with the idea of healthcare providers in mind. But if a public health authority is going to be a participant, you need to make sure that the participation agreement is appropriately tailored for the type of access that a public health authority is getting. It's not like when a healthcare provider gets access with the consent of the patient in order to treat the patient. This is the government getting access without the consent of the patient. And so that's a different type of thing. And so the arrangement or agreement with the health information organization, you know, needs to be clear about exactly what is going on. So then on the next slide, I have some examples, and I'm not going to go into any detail, but just to show you that this is already happening in New York State. So one of our regional health information organizations is Healthy Link, which is in the Buffalo area, and in Buffalo and in Rochester, and also in the 8 western counties of New York State, public health authorities are accessing information using the Healthy Link Rio and the Rochester Rio, and it's improving the ability of those public health authorities to do public health work. On the next slide is a statewide effort to end the AIDS epidemic in New York State. So one thing that we now have legal authority to do is to use our HIV registry, not just for epidemiology, but for the first time to actually contact providers and make sure that the individuals are linked to care and are retained in care so that they will get treatment and be immunosuppressed and reduce the number of AIDS cases in New York State below epidemic proportions, hopefully by 2020. That's our goal. So on the next slide, there's some text there that describes what we're doing. We're taking information from the Medicaid program and information on the HIV registry, and we're linking it together, and we're making sure that the HIV registry is accurate, and we're making sure that the Medicaid beneficiaries who are HIV positive are actually linked to and retained in care for being HIV positive. So that's something that we're doing now. Now, one issue with that is that there's always been a rule, which is the federal Medicaid law and regulations, that says that Medicaid data can only be used for purposes of administration of the Medicaid program. So it's always been a little bit unclear from the federal government exactly what they consider to be for purposes of administration of the Medicaid program. The federal government has wavered back and forth about whether public health is for purposes of administering the Medicaid program or not. So just to point that out, that's one issue there. Okay, on the next slide, there's the biggest RIO, which is in New York City, which is HealthX, and they're involved in a number of different initiatives to share information, both with us at the state level and also New York City for public health purposes. So right now we're working on a HRSA grant where we're going to be accessing information from the HealthX RIO in New York City, again, for the purpose of figuring out how this type of system can be used specifically to end the AIDS epidemic in New York State. On the next slide, there's a few things that are happening in New York City. One of them on slide 24 is, so this is, again, going back to the government being a healthcare provider. The New York City Department of Health and Mental Hygiene actually provides health care services to inmates in New York City. So here they're just participating as a healthcare provider. On the next slide, there's something called the Primary Care Information Project, which is another project that New York City has with HealthX to use information for public health purposes. On the next slide is just another example of New York City Department of Health and Mental Hygiene accessing information for public health purposes. So similar to what's happening in Western New York City Department of Health has started to tap into the system to do traditional public health work such as communicable disease investigations. On the next slide, there's actually a couple of slides about something called family reunification post-disaster. So the idea here would be if there was a public health emergency, such as we've had in New York City, most recently Hurricane Sandy, but it could be any manner of thing where it's some big disaster and people are trying to track down their family members. They don't know where they are and they're trying to find out if they're in a New York City hospital or nursing home, or if they've been moved or whatever. This system allows members of the public to call up New York City, and on slide 18 there's a screenshot of what it looks like. People can call up in the event of a disaster and locate their family members who may have been relocated or may be in the hospital. Okay, so now on slide 19, the first bullet point is something that I already mentioned, which is that when the government is accessing information from one of these health information organizations, you need to be clear about whether the government is doing this as a public health agency or whether we're doing it as a healthcare provider or whether we're doing it as a health plan. This needs to be spelled out in the agreement and it needs to be clear, and it's quite possible that a single government agency is wearing more than one of these hats. Maybe they have to have more than one of these agreements. It gets very complicated. For example, in New York State, we've got the New York State Department of Health, the New York City Department of Health, and then we have 58 counties outside of New York City. So there are a lot of different public health agencies accessing information from a lot of different health information organizations. So, ideally there's a need to standardize this whole process and all of these agreements, and that's a challenge, but that's something that we're working on now. What we've done so far is really a bunch of ad hoc agreements and programs and grant-funded initiatives, but as this develops, we're going to need to standardize the whole thing. So then on slide 20, again, Medicaid program as a health plan is also trying to take advantage of this system in order to do care management. So in New York State, there's a couple of programs here, the Medicaid Health Home Program and Medicaid Delivery System Reform Incentive Payment Program, DSRIP, and these are different ways that the Medicaid program, just like all health plans, private and public, are trying to do more care management in order to increase the efficiency and quality of health care to the enrollees. Okay, so then on the next slide, slide 21, another thing to think about is when the government has all of this information, we're going to use it ourselves for the things that we do, such as, public health work. But once we have this big data bank of information, people outside the government are also going to be interested in accessing that information. So, obviously we can't just make the information public because there's confidentiality concerns, but there's different levels of information that could be perhaps made public in different ways. So you can have a totally de-identified type of file which is available to anybody, and New York State and New York City already have those type of systems. And then at the next level, there could be the possibility of researchers getting information to partially identified information as long as they agree to keep it confidential, or you could have a research project where the subject of the information has actually consented to be a human research subject. And there's other possibilities as well, but that's just one final thing to think about as these systems are being set up. So that was a very quick overview of a lot of different things that are going on in New York State, but I will be happy to answer questions when we get to the question and answer period, which I believe is now. So that's it for me.